Good morning. This is Oasis XP. My name is Sanjay Ranavel. Welcome today to our panel. This is our nurses panel on testing employees and students for COVID-19. Joining us today are Heather Callahan from Avon Old Farms. Hi, Heather.
Hi, how are you?
Good. Thanks for joining. Heather's going to help me with moderating. Also joining us today is Amanda Boardman from St. Andrew's School in Texas. Hi, Amanda.
Hi. Hi.
And Gretchen Inman from St. Stephen's School in Texas too. Welcome, Gretchen.
Thank you.
Well, listen, we have a really very large crowd here today, close to 250 schools, and probably the largest congregation of nurses online that independent schools have seen. This is a very important issue. Just a little bit of background on Oasis. Oasis is an innovation network. We focus on schools, independent schools nationally. Wellness is actually one of our major focus areas, and 2 years ago, we started looking at doing conferences. We just did a recent conference in Boston, not in Boston, in LA on wellness, and we have another one that's planned for Boston. And so this conversation really fits into what we've been doing. What we're trying to do today is really to give you a sense of the landscape here. And we have put together a series of slides together that give you a bit of the overview of some of the issues. Although this is a panel mostly of nurses, there are lots of administrators. And of course, you guys are part of a task force generally that's examining what you should do. So the plan here is to have something that could be shared with your task force in terms of a video. You'll get a link to a YouTube upload at the end of it. We actually have quite a diverse set of opinions. I've talked to all three of our panelists, and they're coming at things from a slightly diverse perspective. I'm going to give you my perspective too. We also have people representing K-12 schools, 6 through 12, and boarding day, which is great. So put your questions into the chat thread. Heather is going to monitor the chat thread. At the end of it, we will also take some questions. Put your hand up on that function, and we will recognize you and unmute you, and you can give us some comments and questions. So with that, let me start by providing a bit of an overview and take you through some of these slides, which you can see, I hope. The reasons for testing are really quite varied. And there could be a number of reasons why schools go down this pathway. I think the first one is compliance. And for some lucky schools, they actually have strict guidelines, and Heather's going to talk to some of those guidelines in Connecticut, which require schools to do certain things, boarding schools and independent schools. So from a legal perspective, and of course there are compliance guidelines which come out at the local health authority level. Then I think the second big one is risk management. And obviously schools are in the business of risk management, and your standard of care can come from all kinds of different areas. Of course, it can come from compliance, it can come from what public schools are doing, and it can come also from what you think is an appropriate baseline. Now, this is probably the most controversial area because people are really not sure whether risk management is possible in these circumstances. You can get a test for COVID, and then literally 5 minutes later, you could go and meet someone who has COVID, and the test could be made worthless. And the same applies, of course, to doing a temperature check at a school. And 5 minutes later, you run into someone who's asymptomatic, and you get COVID from them. So the whole risk management issue is really quite a difficult calibration. And I think we need to talk a little bit more about that. The third area, of course, is your mission. And schools have generally prided themselves on being safe places. Safety is usually the #1 reason that parents send children to independent schools. Some schools are looking at this from a differentiation point of view and being able to say, particularly from admissions, that they are really making an effort to create a safe space. Some schools are seeing that there is a real demand from the parents for some testing. And then I think the final area is, of course, the business model. Independent schools really charge a very significant tuition, and it is pretty much imperative, just like for colleges, that we stay open. And an online model is not a $30,000 or $50,000 model, and therefore it's difficult to justify that tuition at those levels. So that's a general overview of why to test. Let me then take you through some of the components of testing. And just for the benefit of those who are not nurses, let's talk a little bit about the types of tests. And the two words that are important here are sensitivity and specificity. And sensitivity really means accuracy, and in particular, a low amount of false negatives. And specificity means that the test is identifying the right disease and it's not some other disease that's similar. So you have three types of tests primarily. You have a PCR test, that's polymerase chain reaction test, where the RNA is generally, or some of the DNAs or RNAs, amplified using a sophisticated machine that is run at what is called a CLIA lab. And a CLIA lab is a federally regulated lab, usually accredited by the College of American Pathologists. And these are the kind of gold standard tests. They are very accurate, 98 to 99% accuracy, sensitivity, and 100% specificity. They target active infections. Then you have the antigen tests, which don't require you to send the sample itself to a lab. It's kind of like a lab on a swab type approach, not as sensitive, around 80%. Specificity can be very, very high, but again, it's targeting an active infection. And then you have the immunity antibody tests, which really are only sensitive after 1 to 3 weeks. They can be pretty sensitive after that and specific, but it's targeting past infection. So hopefully that provides a context. In terms of the cost of testing, the most expensive tests are the lab tests, and the lab tests run anywhere from free, if you've got symptoms, to around $150. Medicare reimburses it at $100, but really those are only when you have a doctor's note or you've been given approval because it looks like you have an infection. The antigen tests that are hoping to appear are meant to be somewhere in the region of $5 to $20. And the immunity antibody tests, which I think have already appeared, are also in the region of about $20. Going on, in terms of the type of sample and the type of swabs, the PCR tests have various different types of swabs. The most common one, of course, is the nasal pharyngeal one. There's also a saliva test that's just been approved, and there's, of course, an oral swab too, oral pharyngeal swab. The antigen test is a blood sample, and the immunity antibody test is also a finger prick type blood sample. In terms of those swabs, it's clear that this is an article just from a few days ago, that whatever those swabs are, even though they are produced usually with a 3D printer, they are pretty sophisticated. They have to break off in certain ways, etc. And it's predicted as colleges and schools and everybody else gets going in the fall, there's going to be a significant demand for these testing swabs and probably a shortage of them. In terms of the sample prep time of the swab once it's taken, usually the PCR tests take about 2 to 3 minutes, depending on what type it is. If it's an oral or a saliva test, it can be a little bit more if it's a nasal test, because you have to put a swab right the way up the nasal canal to the pharyngeal area at the back. The antigen test is not just a swab, but also making sure that you've got the results. So it's a little bit more, 15 minutes, and the same for an antibody test. In terms of the turnaround times, here is the difference. Really about 4 days on average for our PCR tests. 24 to 48 hours after arrival of the lab is usually what you can expect. Then, of course, you've got the transportation, 24 to 48 hours. Usually, if you order something online, it takes 24 hours to get there, and then you have to send it back, another 48 hours. Connecticut is using 4 days as the kind of guideline, I think, to do a test before 4 days. I think it's because of these two turnaround time elements. An antigen test obviously can be done very quickly if you've got the right machine. I think there is a kind of toaster-sized machine that Quidel is using. There's quite a big installed base of those somewhere, and the same for the antibody test. And then you've got this big issue, really, in terms of context, of how we can scale up the testing. And testing has become, as you know, quite a political issue. This is an article just a few days ago that came out after Dr. Birx, who is well known right now, advocating that one way to actually increase the testing is to do pool testing of PCR samples. This is how China in particular and some other European countries have scaled up. When Wuhan recently did 11 million tests, they didn't really do 11 million tests, they did less than 2 million. They pooled 5 samples together and put them into one sample, analyzed that one sample, and then if there was a positive in that particular sample, they redid those 5 samples. This way you can reduce the cost and you can significantly scale up the much more accurate type of testing. So I think that even though she's encouraging here the labs to do diagnostic testing with pooling, I don't think there's much pooling going on at these labs, probably because it's not under the validated studies that are usually submitted. But pooling is definitely something that I think will be pretty widespread over the next 12 months. So you obviously know that Oasis has a partnership with Centogene. We examined the whole pooling question with them. Their guidance on pooling is that really it should only be done after there's a baseline. And that baseline should establish that the overall prevalence is lower than 1%. And once you've done that, then you can start thinking about doing repeated pooling of samples. Pooling obviously has economic advantages and diagnostic advantages. And you can see that the sensitivity, this is the sensitivity that their CEO gave me on their pooling, but I think they're obviously going to be doing more and more studies on this, but you can see that the sensitivity doesn't drop that much when you get to 1 to 3 to 1 to 5, drops to about 95% at 1 to 6, and then you end up doing more analysis, of course, on those. But this is a strategy that could be a dovetailing strategy. So I'm going to finish off by putting all that together and telling you what Oasis would recommend in terms of what schools could do. I usually kind of think of a fictional, imaginary Oasis school. In this particular case, I'm going to assume the school is both boarding and day, and here are my recommendations. And after that, I'm going to turn it over to Heather, and she's going to talk a little bit about her stuff. So here are the Oasis recommendations. My recommendation is that you establish a baseline, and you establish a baseline with PCR testing. Now, that baseline with PCR testing will obviously be much more accurate. I would go with the Connecticut recommendations of 4 days before or the first day of school. Now, if you do the first day of school, and that would apply to both boarding and day school, if you do the first day of school, I think you need to do strict distancing until you get the results in the first week. And I don't think that expecting students to source their own PCR tests and results will be practical. You can see that already some states are refusing to admit students from certain other states or people from other states and requiring quarantine. This baseline will provide you with some information to manage the most important opening. And that opening, I think, will require you to think about doing further testing. Now, testing is expensive. And so what I would suggest is that with a baseline, you continue the testing 2 or 3 times more, but this time dramatically reduce the cost of it by pooling. And pooling maybe at 1 to 3 or 1 to 5 that keeps your sensitivity above 95%, or at 1 to 5 or 1 to 7 that tries to keep your sensitivity above 90%. Now, with both of those, you'd have to use PCR testing. But then if you wanted to go further and go down to an even lower level, which is more equivalent to antigen testing, you could use PCR testing or antigen testing. And this way you have really got a risk management profile that allows you to do that. Will the cost be affordable? I think if you can do this for around $250 or so per student, I think our parents would pay for it. And you can, of course, check that by surveying them. And I think you need to do this again in January and spring break, except if you do it in January and spring break, you would eliminate a body, hopefully, that has already got herd immunity. And you would use a cheap antibody test to reduce that population that would need PCR tests coming back from Christmas or the winter break or for the spring break. And this way you have a way to really manage it. The other piece of advice I would give you is I think you would want to make sure you secure the swabs and the sample now, at least for 2 to 3 repeats, because there's very likely going to be a shortage, as that article recommends. So that's my overall recommendation. And with that, I'm going to stop sharing and I'm going to pass it over to Heather.
Sanjay, I did see a question in the chat box about pooling. Can you explain just one more time how that actually works? And you take a bunch of samples, correct?
Yeah. Yeah, so basically the way pooling works is that everyone takes a swab, whatever the swab is, nasal, oral, and they send it to the lab. When the lab receives all the swabs, it says, okay, we're going to clump these into 5 or 7 or 10. And they then take the swabs and make it into one particular sample. And then that sample is amplified in the machine. And that reduces the cost of amplification. And then if that sample is positive, you have to redo those 5 again, because you want to know exactly which of those 5 actually was positive. So you only redo the ones who are positive, and this way you can dramatically reduce the use of the machine and all those stuff. So although there's prep time and all that kind of stuff, this is a way to do that. I can tell you that there are tons of colleges and private liberal arts colleges and others looking at this pooling strategy because it's the only real way to maintain a certain degree of accuracy, but still survey a large population. Does that help?
Thank you. I already see some questions coming in. Do you want us to just go?
No. I'd rather do those at the end. I really want to get your views first, okay, and then we'll do those at the end. Great. So over to you.
Great. Thank you. Welcome everybody from Connecticut. I feel very lucky, yet challenged, that Connecticut has given all of the independent schools, both boarding and day, some very detailed and specific guidelines about how to reopen our schools safely. And I'll talk a little bit specifically to testing, although these guidelines talk about a lot of different aspects and areas of our school in how to reopen safely. So we had higher ed guidelines that came out at the beginning of May, but it did say in those higher ed guidelines that boarding schools, especially residential schools, do follow similar guidelines as higher ed because of the similar residential issues. We have also had guidelines specifically for independent schools, K through 12 independent schools. And the areas of testing that I think are most important, and this is how we went about originally planning our reopen and how to repopulate our campus and testing. The first thing that they talked about was a test result, a negative test result needed before your kids come to campus. The first guidelines that came out actually said on the day they return. And then they realized that the logistics of this were going to be too difficult in order for the smaller schools to be able to test all of the faculty and staff, all of the students on the day of arrival. And it also would put some pressure on us to do the quarantine or the quarantine situation while the kids are waiting for their test results. So they actually extended that to 4 days prior. They're saying all students and student-facing staff are required to have a negative test result prior to coming to school. Then they recommended that we do a second test on all of those people 7 to 14 days later. And then again at intervals throughout the school year. Now, this is all just the baseline testing that Sanjay was talking about. So this would be testing using a PCR test, because we know that the PCR test is the best test for asymptomatic people. The antigen test would be for symptomatic patients only. So we did get a machine. We have not gotten our hands on it yet here in the health center. We have an agreement with the Sophia 2, the Quidel machine, to do antigen testing here in the health center. It's a rapid test. We get results from 3 to 15 minutes, and we're going to be using that on all of our symptomatic students. So anyone that walks in here with flu-like symptoms or any COVID symptoms, we will be testing. And we will probably have a very low threshold of testing, at least initially. And unfortunately, I think that means anyone that walks in the health center with GI symptoms, headache, loss of taste, any of those symptoms are going to be getting one of these antigen tests here in our health center. The challenge that we face with the baseline or the asymptomatic testing, both before returning to campus and again 7 to 14 days later, are some of the things that Sanjay already mentioned. So number one, it's cost. And I can tell you that my administration, when I first did some numbers out for them on what it would cost to pay for our employees to have 2 tests done within the first 2 weeks of coming to school, and their eyes bulged out of their heads and said, no way, we can't do this. It's a huge number. When you look at approximately $100 per PCR test, if you have 100 faculty and you have to do that twice when you first come back to school, and then again if you repopulate in January, and if you have to shut down and repopulate after that. So the number grows very quickly. And that's just for your faculty and student-facing staff. And then do you ask students and their families to pay for these tests? Again, that's a lot of money out of pocket. And the big issue right now is that insurance companies, they're just not paying for these tests. They'll pay for symptomatic tests, absolutely, 100% coverage for most good insurance companies. But in terms of systematic, sort of the baseline asymptomatic testing, right now insurance companies are not paying. So I have another nursing director here in Connecticut that I work with closely, and she said it's kind of along the lines of the state mandating vaccines and then not paying for it. So we're really frustrated that we're being told that this is the kind of testing that we need to be doing, but yet we're not being given any money to pay for it, and insurance is not paying for it. So that's one of our biggest challenges right now, is figuring out who's going to pay for it, how we're going to do it, logistically with our health center staff. I have a staff of 4 to 5 part-time nurses. I'm a full-time nurse. I have one other full-time nurse. If we have to collect and process nasal swabs for 400 kids and faculty and staff, I'm putting my health center staff at risk. I'm increasing their exposure. One of my nurses goes down and has to be out for 14 days, we're in trouble. And just the time of that, right? To process all of those, to do all of those swabs, not to mention the PPE that you have to put on and change out and use when you're doing those swabs. So logistically, to do all of those tests here on campus is just a nightmare if you start to think about all the details. I know, so actually just yesterday, we had another set of guidelines that came out for the higher ed institutions here in Connecticut that's starting to change testing policies and guidelines. This one actually allowed 14 days prior to coming to campus, which doesn't make a whole lot of sense to me. It gives us more time to process those test results that would be coming in from our students. However, if you ask a student from California, and now we're in Connecticut, to get a test 14 days prior to coming to school, then they hang out with their friends before they come back to school. They get on an airplane, they're in an airport, they may have to take a bus to get to school. now we have 2 weeks worth of possible exposure. So they increased that time to 14 days. They told us no longer do we have to do a 7 to 14 day repeat test, but their suggestion now, and I think this is to deal with the logistics of collecting that many samples at one time, they've said 5 to 10% of all of your residential students and staff should be tested weekly. So I think what they're trying to do is spread out that asymptomatic testing throughout the fall. But again, we don't really know. We haven't had a chance to communicate with the people that gave these guidelines. They are very open to questions, comments, and looking at the challenges of these documents. We are waiting for an independent school testing guideline to come out. That should be coming out soon. So we'll see how that's going to be different for the independent schools versus higher ed. But those are some of our challenges, obviously, logistics, staffing, insurance, cost. Our heads are spinning, and as many of you probably know, our inboxes have been full of companies now that are coming out of the woodwork for testing and providing you mobile units to come to campus. It's a little bit overwhelming. So we'll see. It's constantly changing. I think our school communication is going to say we have a testing policy, but we know that that's going to be changing probably on a week-to-week basis. But as you said, Sanjay, I do think that we need to start putting some things into motion and starting to at least acquire some of those testing materials so that we can be ready.
Just one question for you. So the guidelines from Connecticut, did it say anything about independent boarding day schools?
Yeah, well, so in the higher ed report, it actually talks about the difference between residential and non-residential programs. Residential programs have the testing requirements. The non-residential programs, they actually put into a category of like a local business. And so there is not the same asymptomatic baseline screening that they are requiring for non-residential programs. That was in the higher ed report.
Got it. I mean, basically, it sounds to me like what Connecticut is doing is they're trying to work out what testing capacity is available, which is pretty limited right now, right? What the price is realistic for congregate settings, and then kind of hashing out some kind of epidemiological strategy out of that as best suits those constraints, right?
Correct.
Yeah, okay. Brilliant, that's very helpful. Over to you, Amanda.
Thank you. So I'm at a K through 12 day school, which does present some, of its own benefits and challenges. And so, as we're starting to look at testing and seeing what makes sense and is possible, I have to keep in mind that I'm sending kids home every day, one, to just their families, but two, then to wherever else families may take them, whether that's extracurricular sports, after school activities, other family members and things like that. So, as we look at the testing, if we're doing something like a repeated frequent testing, which we're not sold on, for sure doing at this point, but kind of thinking through what would the logistics of those look like. The first piece of that, I think, is that we would have everybody antibody tested at the very beginning. And while we know we still have questions, there's still information coming out as far as how long would that immunity really last. All of the recommendations that we're getting from doctors that we're in touch with, people that I've talked to with the testing, is that really we work on a trimester system. Is that we have people who are positive to have those antibodies. I can kind of set them in another category for one trimester and not worry so much. I remove them from this need to repeatedly test. And so then, likely that number is going to be low, but it does take away a little bit when we're looking at the cost and things like that. The next thing that we would potentially look at would be, some of the PCR testing, which As has been shared here, the cost of that is really what may be a limiting factor. The ideal timeline, I think, for that is every 2 weeks. You can do that on a rolling basis to eliminate some of that mass quantity that your health center might have to deal with. Less ideal, but still useful, could be on a monthly basis. Doesn't quite get you in that 14-day window, but does still give you, a good sample size of your population. And then even without that, if we were not to be doing the regular testing of everybody, being able to have the accessibility within your health department, even at a day school, I would find really beneficial to be able to test anybody that comes through with symptoms. So the ability to put a student into a room, we're waiting for parents to pick up, and I've already run the test. I'm already in the process of getting that test sent to be analyzed, and allowing the school to have a hand in some, you get two pieces out of that. You get a piece of control where you're going to know that you're going to get the information back. You're not chasing down a family or a parent. You're expediting the timeline in that. And then also being in an independent school, you are providing a service that a lot of those families are going to appreciate, having tests done here and now. And hopefully that is going to quicken your timeline a little bit to then be able to do any contact tracing within your school building that you might need to do. Now, another interesting model that I'm considering for this is looking around our faculty and staff. And so, and really I see this as a benefit to our faculty and staff would be to offer that PCR testing on an every other week, every 14 days basis for the faculty and staff. Those are going to be our high-risk people. We continue to get more and more information that our students are not great vectors of this. And so being able to say, we appreciate the fact that, as faculty and staff, you are coming in, you're putting yourself into contact with these students. You are more likely to maybe have elderly family members at home, be in a higher risk situation. So we want to afford to use this testing every other week to kind of, one, to know, that what teachers may be asymptomatic and not wanting them to spread it to any other teachers. But then also as a little bit of an assurance for themselves of what they've potentially been exposed to. So that's a model that that's a thread that I like to pull the most, is thinking about how we think about those who are going to be most vulnerable in our population.
So you're putting a lot more emphasis on the faculty than the students.
I am. The research that is coming out now is not only, that our students are getting mild cases, mainly asymptomatic, and that they're less of vectors. They are, 1/3 less likely to be spreading it to their teachers or to their households. But our teachers, as asymptomatic carriers, they're going to be better vectors to then take it back to, a potentially immunocompromised partner or family member within the home.
And they are also talking a lot more generally.
Yeah, absolutely.
Right.
Can I see a bunch of questions about the antibody testing. And so, Amanda, I know if you're using that in your school as a way to sort of plan out your testing policies and protocols, can you explain a little bit more? People have heard, right, in the news, sometimes there may be reinfection, or does this really confer immunity? Can you talk a little bit? There's a bunch of questions about antibody testing and sort of the uncertainty that's out there still.
Yeah, so most of the research that's coming out now is really not suggesting that people are having a reinfection, but instead that they're able to shed particles of the RNA through the nasal cavity. And so that when those are swabbed, yes, there is a presence of the RNA, but that RNA is not in a viral load or really even stable enough to be an infection. It's kind of this leftover lingering thing, as some of you may, similar to like a mono, if you will. And so the antibody testing, when you look at it, you can see there is some data that's starting to come out that shows that at 2 to 3 months, that IgG and IgM is starting to fall. But what we know about the IgM and IgG, especially when we look at vaccines, we look at tetanus and other ones like that, is that while the level may start to fall, the big question that we have right now is, what is that threshold? For something like tetanus, that threshold is very, very low. You're looking at like 0.1 IgG for something like tetanus. And so that threshold is what we don't know, but if we're knowing that the antibodies are coming down after about 2 to 3 months, that's where I use that trimester, you know, that I'm using that 2 to 3 month window to know that this person still has those antibodies. And so, yeah, it's not 100% a perfect science, but from the physicians that I've spoken with and the studies that we're looking at, I think that we're feeling like that gives us a pretty good coverage for that. And we're using a shorter window than what some people might be looking at. And that's a finger prick test. That's a 10 to 15 minute, looks similar to a pregnancy test.
Thank you.
Great. Over to you, Gretchen.
Hello. So my name is Gretchen, and I am at St. Stephen's in Austin, Texas. So unlike Heather and much like Amanda, our state hasn't given us the specific guidelines around testing. But before I get into the specifics of sort of my sense of testing, I feel like I want to back up a little bit and say some things that may be a little obvious, but I think are really, really important to keep reminding ourselves of. So one is, I feel like, so one of the thing is that as nurses, and I know most of us on this talk are nurses, you know, we're being asked to analyze a lot of information that's out there, but very little actual scientific evidence. And so we're in a really, really tough spot, and we're asked to be experts on this overnight. So I applaud all of you for all your hard work and for you bringing us together to talk about this and keep at it. So with that being said, is you really have to do your research, and you have to understand testing, and you have to have an elevator pitch with that testing. You need to be able to say it quickly and to your entire community. So for me, I kind of started with my head, and we went and he had me present that to the reopening task force. And then we formed a medical advisory committee. And within our medical advisory committee, we have a pathologist, we have infectious disease doctor, pediatrician, primary care, global health experts. Even with that, we all have different opinions. So it's really complicated. And so if you're feeling overwhelmed, there's a reason you're feeling overwhelmed and complicated. So I just want to kind of go back to that. And then two, my second point is that these testing strategies cannot stand alone. They cannot stand alone. So if you don't have behavioral expectations, very clear behavioral expectations that go along with these, then the testing strategies are kind of even silly to implement. So I know that seems obvious, and yet we have to keep reminding ourselves that if you are not laying those out in some very specific way of what you expect of your community members, that doesn't really go along with the testing model to begin with. And then three, as we know as medical professionals, those of us that are on this talk, is that we don't order a test unless it's going to change what we do, right? So we need to think about and prepare for the results that we get. And if we're not able to respond to those results, we shouldn't order the test to begin with. So these to me are kind of three obvious places to start. However, I feel like I must reiterate them here because I think if we order a test, we need to be able to respond to it, and does it change the way that we move through? Does doing a test change a person's behavior, right? That's the big question. And if you don't have the behavior changes, I don't think you're gonna have, we're gonna keep our schools as safe as we want to. So that's kind of just my background. The other thing is, as we all know, anything that comes out of any one of our mouths today may be totally obsolete in an hour, or maybe right now. So please make sure when you're kind of keeping notes that you're keeping dates, because that's a really important component. Because as we get more information, things that I thought that I knew really well have changed quite dramatically. And as we look at the media and we hear this school did this testing, or this university did this testing, or this football team, they never really reveal what that testing is, as you know. And so that makes it all the more muddy. And we know testing is not testing is not testing. So that being said, so in terms of when I look at, and you did a great job of kind of laying out the difference of the different testings. For me, when I look at the research, and again, we're looking at, as medical people, we're used to looking at big bodies of research, right? Double-blinded, placebo-controlled studies, which we don't have large samples. We're looking at these tiny samples. But based on what the research is showing me and what I've looked at is that the PCR nasopharyngeal swab is the gold standard, if you could even say that at this point, and certainly the most accurate. And so as a medical professional and as a clinician, that's going to be sort of my go-to. Even that being said, so he laid out the specificity, et cetera, and the reliability. The reality is, even with a PCR test, the test itself is very accurate. However, the clinical application of it, there can, even with that test, there can be a 15 to 20% false negative. And the reason for that is not because the test is faulty. We don't really know when in the virus cycle to do that. We really don't have a good understanding. Is it too early? Is it too late to collect the sample? We also don't know, is there a specific time of day? I bet we'll find out down the road that maybe there's a special time of day that is recommended. The other piece of that is, the swabbing technique. Are you in the right place? Are you using the right technique? So no testing company can account for all of those pieces. Those are pieces that happen in the clinical setting. So if we look at that, and on typical, you can miss 15 to 20% of the positives, even with sort of what I consider the best test out there. So you have to keep that in mind as you're making these decisions. None of this is foolproof, and you do the best you can in what decision makes sense for your space. So as I think about this, my recommendations to my school have been to use the PCR and to use nasopharyngeal for symptomatic people. And if we go to a asymptomatic screening situation, that would be my recommendation. And yes, you totally hit it. Both of you did. The logistics around doing that. For me to do all of my employees with 10 medical professionals out there, it'll take us about 5 hours. And what is also different about Connecticut and Texas is the heat. In August, being out there in your PPE with the cars driving by, it's a lot. But I do think—
what's the amount of time per nasal thing that you would need?
So, 5 to 10 minutes, depending on the person, because you've got to do some anticipatory guidance. You've got to, put labels on the tubes. You've got to, so that's what you'd want other helpers around that are not medical to help you kind of make that flow a little bit better. Some people are going to be very anxious. Some people are going to be, not as anxious. So when you're dealing with that, so the rapid antigen tests, while they sound great, I can get results really quickly. I'm pretty skeptical about them. I'm skeptical about the newer tests. And I also, there's the CLIA waived piece. So, some of these are not CLIA waived, and that's important in our clinic settings, depending what our settings are. They're not as reliable, and I feel like they need to be backed up with a PCR. And so for that reason, I feel skeptical about using those. Do I have a lot of hope for the future in those? Absolutely. Absolutely. I feel like there will probably be a more reliable CLIA waived machine down the road that is accessible. That's the third part, that's accessible. So some of these things—
Can you just specify what you mean by CLIA waive for people who don't understand that?
So, in our school settings, basically the gist of that is that in our school settings, for us to be able to do anything with certain types of bodily fluids, we need to, so to back up, the labs that are doing the PCR testing are CLIA, right? So they can do this, they can deal with lots of bodily fluids. So for us to deal it with in a limited way, for example, like a strep test or a flu test, which are things we might do in our offices already, those are CLIA waived things. And so to be able to do certain tests, you need to have that waiver. And in certain situations, we won't ever be able to do them in our schools because we're schools, we're not hospitals, we're not clinics, we're not labs.
Right. And the PCR tests have to be not just clear, but clear, highly complex.
Yes, exactly.
There are 3 different levels.
Yes, agree. And then the antibody test, again, I feel like I'm advising my school to not go down this route at this point. I feel like we don't really know what this means. Yes, it can show evidence of a past infection, but remember, and part of, obviously, you know, kind of one of the first rules in making decisions for our schools is looking at our local infectivity rates, right? Which highly influence the results of the antibody test. So as you know, so number one with this antibody, we don't know whether the antibodies are neutralizing, meaning we don't really know if they're showing that immunity. And so we're looking at, you know, previous SARS, et cetera. But when we look at SARS-CoV-2, we don't really have that answer yet. And so I'm hopeful that we'll have more information in the future about that. But I do feel like, you know, that concerns me. This is a, you know, reportable disease. And if we're getting lots of false positives on this, we're reporting falsely and giving a false sense of what's going on. So I do worry about that quite a bit. So I don't know, I'm going to back up and just make sure you guys know, if there are a lot, if there are not a lot of cases in the area, you can have about a 50% false positive on those. And if you, but as you increase your cases in your area, that goes down quite a bit. So certainly it's going to be a much better situation to use if you have a lot of cases in your specific area and in your lab that you're using to test that. So that's kind of my kind of rundown on those kind of three types of tests. In terms of pool testing, I think that I wonder, you know, about the cost analysis of that. Are we really going to be saving money, or are we going to be having to, you know, repeat on the individuals? Certainly, if you're considering pool testing, you want to ask about validation studies from those companies and methods of validation before you just go blindly.
Yeah, they have to, pool testing has to have validation studies because it's done at Clear Labs, and Clear Labs cannot do PCR testing without validation studies. Otherwise, they'll lose their College of American Pathology accreditation.
Yeah, so I'm just encouraging you to dig in and ask those questions. And because I feel like, you know, as nurses, I don't want to be reiterating the myths that are out there that we all see and read every day. And I feel like it's our job to educate our communities and our constituents about really the limitations of testing, the pros, the cons, and the limitations. And there are some for all of those categories. And I think we need to be aware of that as we start making decisions and help guiding our schools in these decisions that we're making. So for example, as I told you, I of all the tests so far, I'm the biggest fan. I wouldn't say I'm a big fan, but I'm the biggest fan of the PCR nasopharyngeal swab. But given that I told you that from a clinical setting, we have that 15 to 20% false negativity situation. So if we do that and we're quarantining, if we receive students, boarding students, and we do that, if I get a negative, I'm not going to recommend taking those people out of quarantine. I would recommend continuing with a 14-day quarantine, even with a negative PCR test, because of that 15 to 20%. So
I think it's great to have your opinions on this. Can you also share your opinions on the thermometer conversation that we had yesterday? Because that your equally skeptical views on that, I think, should be aired, please.
So yeah, I think the daily screening, self-screening is really important, and I think asking those questions, you know, of individuals. And to me, when I think of individuals in our schools, I think of kids and adults one and the same in terms of kind of those things. So the screening questions are really important to ask every day. And as people get more comfortable and more safe, they feel less inclined to do those screening questions, right? Because they take your safety for granted. So having to do those every day is really important. Part of those questions do you feel feverish, right? So you're kind of assessing so one is a sign, one is a symptom. As nurses, we know kind of the difference there. And so one's an objective measure, one is, you know, a reported measure. But if you're feeling feverish, that to me is a time where you take your temperature. All of my school nurse friends I know can tell you it's very rare to see a febrile person first thing in the morning, even with a diagnosis of the flu or something, you know, anything that is a typical febrile illness. Our bodies do not usually spike fevers in the morning. And so if we're using first thing in the morning as a criteria, just the physiology of that doesn't make sense to me. And so when I see a kid come in, and I know you have seen this patient before, that comes in at 8:30 in the morning and they're 99.2, you know, by 4 in the afternoon, they're going to be at 102. And I call the parent, or if they're a day student, or I treat them as if I feel like they're going to spike later. So looking at the same temperature criteria for a morning and an afternoon doesn't make any sense to me. And therefore, I feel like when you ask someone that daily morning temperature screenings are not necessarily the way to go. I think if you if you are symptomatic, if you have other symptoms, you have a sore throat, take a temperature. You feel feverish, take a temperature. You've had a contact, take a temperature. You have a travel risk, take a temperature. To me, that makes more sense than taking an early morning temperature on every person.
Yeah, I have to iterate what we also heard at the legal webinar that we did, which is also taking a temperature should be done in a place generally where it's enclosed, because there are privacy issues regarding taking a temperature. I suspect most schools have been thinking about taking temperature at carpool lines, like restaurants, which, by the way, certainly in California, are not taking temperatures of anyone. So I think this whole temperature thing, which has basically been seen as a kind of optical risk management strategy, has started to be thrown out. We'll see.
Yeah, and I know some states some people have it's being mandated that they do that. And so that's a different issue. But right. I just feel like, as nurses, we have to go back to the science and the physiology. And I mean, you guys know, if I see somebody with a 99.2 first thing in the morning, that speaks to me in a really different way than a 99.2 at 8 o'clock at night.
Yeah.
Totally different things.
That's perfect.
And so I think they need to be looked at differently.
Great. Well, listen, let's take some questions. So thank you, Gretchen. That was really great. Put your hand up on the screen and we'll recognize you. If you have anything, I know Heather has been going through the questions. Are there any particular questions, Heather, that we should throw out to the panel right now?
This is just sort of a quick one, and Amanda and Gretchen, maybe you can give your what you've seen in your area as well. Is student insurance, as far as you know, will they cover the antigen test? I know here at Avon Old Farms, our international students all have the student resources, health insurance that we get through the school, through the school. We have heard from that insurance company that they absolutely will pay if they are symptomatic and anything related to COVID or a possible COVID diagnosis, they will cover 100%. I also know that our faculty health insurance, Cigna, will cover a test if you are symptomatic. However, I think the challenge here is the baseline testing or the asymptomatic screening testing right now, as far as we know, is not being covered by insurance. Is that what you guys are seeing as well?
Yes.
Yeah, only for symptomatic.
They're not going to cover asymptomatic because otherwise they'll be out of business. I mean, they have their own costs too. So it's yeah.
And then another sort of logistical question: how do you order a test at a school? I know we have a medical director who's a local pediatrician in town, and our thought was, and again, we have not worked out all the logistics of this, but our thought was that he would write a requisition, an order. We would put it on Magnus. We use Magnus electronic health records, and parents, no matter where they are in the country or even in the world, they can download that form, that order form. Obviously out of the United States, it wouldn't work, but they would then take that order to a clinic or mobile unit or something in their area and be able to get the test done with that order. Because as of right now, you still do need an order, a doctor's order, for any type of COVID test.
But don't you need? It depends on what kind of place you're going to, right? I mean, most of these CVS or elsewhere will want to have a doctor's order that says that you're symptomatic in some way.
So our doctor has, I believe he called it, I'm trying to remember what he's done in his practice. He calls it fear of disease with no evidence or something like that. There's a code, an ICD code that you can say basically, so the parent that walks in and says, I think my kid has COVID, I want to know. And so his ICD code, it says something along those lines of fear of disease with no evidence of disease. And so far that's been working.
I can tell you that if you go on to LabCorp, right, or someone like that to try and get a test, they're going to ask you a questionnaire. And on that questionnaire, you will be disallowed if you don't pick one of the options that's related to symptoms, unless you basically say that you are going to be in a congregate setting. And that congregate setting is high exposure area, and school might qualify under that congregate setting. So certainly for our tests that Centogene is going to provide under our partnership, congregate setting is one of those criteria. And so you're going to have to, I think, if you're going to be doing PCR testing, have a questionnaire question that relates to that in some fashion, even though it might not be covered under insurance. What else, Heather?
Let's see. Could you readdress the issue of the RNA shedding and viral load? I think somebody, I don't know whether that was you, Sanjay, or Amanda.
I think I spoke to that, and that was related to kind of the idea of reinfection. And so what that is that what's been found so far in people where they're, saying this person is 2 months out and now they've got a positive test or those kind of things, is that what they're finding is that there's a presence of the RNA, but it may not even be the full sequence of the RNA, but that it's enough to trigger a positive test, but not enough of it to actually trigger either an infection or the ability to infect somebody else. Again, as Gretchen mentioned, these are small studies. These are 5 people that we have this information on, but it is more than one person. And when we're in this situation, that's kind of the information we have to go on. That may change tomorrow, but so far, the ones that they've been doing that on, that's what's been found.
Got it. We have a hand up here. Willow, we'll unmute you. Willow, are you there? Willow Graham? Willow? Willow, are you there?
Yeah, I'm here. Can you hear me?
Yes.
Hi. I'm from High Mowing School in New Hampshire.
Got it.
And I just wanted to follow up on the antigen questing. So we don't do point of care testing at our school, but if we were to get into that game, purchase the Sophia 2 Cadell equipment, are these schools that are doing the antigen testing, are they running the student insurance to cover those tests, or are they paying out of pocket, or how that, I guess that was more my question about if we end up doing the point of care testing, will we end up needing to get into the insurance game as well?
That's still out for debate at our school. The Sophia 2 machine has quoted us at around $23 per test. I imagine we actually cover flu and strep as part of our health center fee, but we are putting out to families this summer that there may be some incidental costs associated with COVID. And so I believe that we will be charging families, although this, don't quote me on this, but I think that's our thought right now, is that if we're going to be liberally testing and have a low threshold for testing, at least in the beginning, we would probably put that charge off to the families.
You may want to check all your HIPAA requirements if you start doing insurance related.
Well, that's our concern, yeah, is that we're then opening a whole big can of worms.
You definitely will be.
Yeah, and I mean, we're a very small school, so at this point, our plan had been to, bring students for testing at local testing centers, but we're just afraid if our, our state mandates something else, that we're going to have to kind of come up with a second plan here.
Right. No, I mean, we addressed that in that other webinar. You might want to take a look at that, but basically the insurance definitely takes you into the whole COVID HIPAA privacy area in a big way.
Yeah.
What else? Thank you.
This might be a question for Amanda and Gretchen as well. Are the nurses at your schools going to be testing faculty, or are you going to ask them? I know we don't usually treat faculty, although I will tell you, if somebody walks in, unofficially, if somebody walks in and asks for something, I'm not going to say no, but technically, you have to have a chart on somebody at the school in order to track what you're doing with them. And again, this is sort of a conversation that the nursing directors have had in the state of Connecticut. Are we going to test faculty? I would love to be able to have a faculty who feels symptomatic walk into my health center and know 5 minutes later if they test positive or not, just for contact tracing purposes and things like that. Are you guys going to be testing? Are your nurses going to be testing your faculty and staff?
So in our situation, again, we're boarding too. I think boarding, lends itself more to that sort of employee walk-in feel. And we do not typically, it was similar to Heather, what you said, we don't typically treat employees. And so, no, we would ask them to go be seen. In fact, if you feel symptomatic in any way, we ask that you leave school and go see your own provider. Now, if we do go into a screening situation where we're doing, nasopharyngeal swabs from a screening perspective, then yes, that would be a different kind of scenario. But in terms of for a symptomatic person, no, because, and in fact, we're trying to keep employees away from the health center to limit the contacts.
Yeah, I would say in a screening situation, we're looking at that. Magnus does have I know both of you spoke about Magnus and many of our independent schools do. They do have the ability for you to create teacher charts within there. And so that's something I'm exploring with Magnus and with our HR is how we might do that. And I am thinking, I mentioned before, I am thinking a lot about this from the standpoint that we're asking teachers to come into a situation where they are potentially more vulnerable than our children. And so how can I, following all the rules and regulations and laws, but still afford to them that extra additional piece of care.
Great. Sanjay, this actually is a great question that's sort of a follow-up to the webinar, the legal webinar on Friday. Will you use a permission to test form with students or families that say they can't refuse if they want to be on campus? And I think that this was addressed they talked a little bit about the ADA and how it's a reasonable risk.
Yeah, I think you definitely have to get student permission to test them, right? And you are allowed to ask your faculty to be tested under the ADA. So I don't think they can refuse, but the student and parent can definitely refuse. And yeah, that's what the law firm was saying. And so what's the question exactly? Is that the question?
Do you need a special consent for COVID testing? We have a blanket consent to treat, and it basically says whatever we deem is necessary. And so it kind of falls under that. We are also putting out a separate document that's going to be probably an electronically signed document or part of our student handbook that lists out a bunch of things that are going to be different this year because of COVID. And people are going to have to sort of sign off on this kind of blanket consent form.
Right. I think, with the Centogene situation, for example, they require that you have obtained consents particularly to HIPAA and GDPR if it's relevant, and the other things that we talked about. And they will, and I think most PCR companies will require a questionnaire that asks you why you're getting this PCR test. I think pretty much everyone, but it can be very simple and say you're getting it because you feel you're afraid, right? That you're going into a highly infectious area of congregate settings. Thank you. But I think you're going to do that. And I think you could probably incorporate that into the other daily questionnaires that you're planning to do, temperature checks and whether you've done this, that, or the other. So yeah, definitely you're going to be putting together a form of some kind.
There was another question. I think I had mentioned mobile units. I know some of the local hospitals have these mobile units that go around to different locations with sort of a mobile testing site. I know that some of the colleges and universities are using these, and the question was, how do you get one of these? We just reached out to our local hospitals. We are lucky enough to have a handful of good big hospitals in the area that we have reached out to.
But those are not for the machines. Those are for those mobile labs are just for swabbing. So it depends on what kind of swabbing you're doing. If you're doing an oral swab or a saliva test, right, and you don't need a nasal swab, then obviously you could do it yourself, or you could do it yourself. So, I mean, the actual machines that do the PCR testing are not mobile, and they have to be attached to a clear lab. And there, as far as I know, there are no mobile clear labs, at least not highly complex ones. So it's really simply for the swabbing.
There were a few questions about the saliva test. Do you have any more information on that? Are you?
No, I mean, the saliva test came out recently. It's, it went through the usual EUA federal approval. I think it takes quite a significant amount of saliva, and you just like with the LabCorp test that you take, do the nasal thing yourself at home, or the Centogene test that you do the oral pharyngeal thing. You basically have to make sure you get a sample at the end from that. And I don't think the FDA would be approving any of these things, quite honestly, unless they thought that they had sufficient validity. So I think the saliva test must be valid to the degree it's possible.
This is another quick question, I guess, for Amanda and Gretchen, and this is something I know I'm working on my medical director with. How are you handling students with seasonal allergies or asthma that have those symptoms on a regular basis? So we know, right, just not feeling great or the sore throat. Would we be sending them home right away? Every time they show up on a new day with these symptoms, how are you going to clinically manage those students?
So I would say, and as I told, my task force, see this list of 11 symptoms, this is what I do all day, every day, is see people that come in with these chief complaints. So I am not a big black and white medical thinker, but I feel like this requires some, and that's why I feel fortunate to have this medical advisory committee. And if your schools don't have them, I would recommend, and getting some more kind of where your threshold is, where your tolerance is for testing, for sending home, for all of those things. I think that's really important. Even thinking about what is your threshold level for temperatures? I mean, some states may have that, some states don't have that. So I think that's really important to get some, I think a team effort, an approach to that is really important. And in my committee, I certainly have primary care people on it, which are gonna have a really different perspective of what do you do with a sore throat that walks in the door versus somebody in infectious disease. Those are really different birds. And so I think you have to, I think collaboratively, I think makes sense to me. And therefore your staff also feels kind of protected in their decision-making. And there seems to be some consistency across the board. That's my thought. I don't know, Amanda, what your feelings are?
Yeah, no, I think similarly. And I think the other thing is that you have to look at those symptoms, and you kind of have to, what we've done with our medical team is to look at those and say, which ones are a do not pass go, and which ones are, let's have a more in-depth conversation. The other thing is you also have to define some of those symptoms. It may seem really specific, but you need to make sure that your entire team understands what the definition of that is. What is the definition of diarrhea? Unfortunately, we need to get really specific on some of those things to make sure that we're using the same gauge.
Got it. Well, listen, we are well over time, and we really appreciate the three of you. Your insights have been invaluable. For all of you who participated, we will send a recording of this video so you can share it with your task force and whoever else needs it. And if you have any further questions, just reach out to us and we will try and answer them. Thank you, Amanda. Thank you, Heather. Thank you, Gretchen. Thanks, everybody. And we're going to call it a day. Thank you.
Thank you.
Thank you.
Bye.